We are live now.
Yeah.
So,
Okay.
good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Med Mocha Meetup Season 1, Session 14. And today's topic is Ovulation Induction Tips and Tricks. So, it's my privilege to introduce the organizer of this webinar, Dr. Ritu Santwani ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is infertility specialist. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. So I welcome you, ma'am, and I hand over the session to you.
Yeah. Thank you, Sahiti, and thank you, Shil Sharma, for providing the platform for this program from last 3 years. So, a very warm welcome to all of my dear friends who have joined all across the geography. Friends, as we all know, the ovulation induction is the thing for which, even though we are practicing from so many years, there is a lot of confusion how to do the ovulation induction, whether to use the clomiphene, whether to use the letrozole, whether to use the anastrozole, or whether to use the tamoxifen. And what are the protocols? These days, so many protocols we are using. For letrozole, we are using the extended protocol, for 10 days protocol, and there are so many recent advances. In some patients, we are using the tamoxifen where we are not getting the good endometrial thickness. So to discuss with all for all this, today I invited a very dear friend and senior संगीता मैडम. संगीता मैडम के लिए एक लाइन कहूंगी, उनसे मेरा कुछ दिल का कनेक्शन है, ऐसा बोल सकते हैं. So Sangeeta madam is a stalwart, a very renowned name in this field. So now later on, whatever the questions related to this, we can discuss later on. May I request Sahiti, please do the formal introduction of madam.
Yes, ma'am. It's my privilege to introduce Dr. Sangeeta Sinha, ma'am. Ma'am has done MBBS, DGO, PGA in ART. Ma'am is ART consultant and gynecologist from the Srijan Bilai Test Tube Baby Center. Ma'am has ISAR accredited center, Foxy recognized infertility training center, and Foxy recognized endoscopy training center. Ma'am has IMA AMS approved Center for Fellowship Course in Infertility and also Laparoscopy Training Center. Ma'am is currently the president of Bilai Foxy OBGYN Society. And ma'am is also IMA Durg Women's Wing India in 2023 and IMA AMS CG Secretary from 2023 to 2025. So I welcome you, ma'am.
Yeah. Warm welcome, Sangeeta madam.
Hi. Can I have my screen, Sahiti?
Yes, ma'am. Please
Yeah,
share
sure.
the screen.
No, I just want my picture, like the shield is there. Okay. So very good evening to all of you, dear
We
friends.
cannot see your slides, ma'am.
No, I'm not posting the slides. I'm just speaking, but my picture is not in the
Okay,
screen.
ma'am. Okay, ma'am. Sure.
I just want the screen to be changed. So good evening, dear friends, and thanks, dear Ritu, for informing me this platform, and thanks, Sahiti, and the SEAL group. So today, as Dr. Ritu told, we are discussing about ovulation induction. And if you think of it's like a topic or a kitty bar every time we discuss these topics. But believe me, this topic is like every time we discuss, we find new things, and every time we find, "Arey, ye mere ko karna tha." So in very short, I will just compile my thoughts and how to take up a patient for ovulation induction, and then we will have the question answer session. Society, I will just share my slides. Is the slide visible?
Ma'am, just a second. I am able to see the Kanchan Sharma ma'am, a very dear friend and dear senior. Our chairperson of NCD committee has also joined from the Kanpur. A warm welcome, Kanchanji. Sangeeta
Thank
madam
you.
also I am able to see. Sangeeta
Thank
Srivastava ma'am,
you,
welcome.
Ritu.
Yeah,
Always,
yeah,
your
yeah.
sessions
Over to
are
you, ma'am.
very good.
Yeah, over to you, ma'am. Over to you. Yes, ma'am. Please start.
So good evening to all dear friends. So today we are discussing the ovulation induction tips and tricks. Believe me, it's a very, you can say it's a simple one. Again, it's a very complex. Not going in detail of what is infertility and what is the incidence and all. But in any day-to-day gynecologists, like you, we all know infertility is increasing, and day-to-day the gynecologists have to face this problem. either the region is male infertility or the region is polycystic ovary, or we are dealing the unexplained infertility, is the burnt the ovary has to be or the female has to be. We have to go for induction. And believe me, ovary is a very dynamic organ. Most of the time you come across like we say, मैडम उनके पास तो बड़े अच्छे अंडे बन गए थे, आपके पास क्यों नहीं बन रहे? Because it's a dynamic organ, its metabolism changes even hour to hour and day to day. So it is very important to understand the basic physiology. Either we are giving any medication, we are giving letrose or we are giving clomiphene citrate, but what the normal physiology needs. That's very important. And again, it's very important. We have nowadays gone where the days when we are very happy, like अरे 12 अंडे निकल गए, so we are very happy. Now for the IVF, we have concised to 8, 9 max to max, and for the IY 2 to 3 follicles is fair enough, because now we are focused for the quality, not for the quantity. We just need 2 good blastocysts to transfer, or 2 to 2 maximum 2 follicles for the IY. So the more concern about the quality. So how to make a good quality embryo or is very important. Again, I to all my students and my close friends, I say these basic things which we have learned in our MBBS days, the HPO axis, that is very important to understand for each and every patient. How to downregulate, how to upregulate. Molecules we all know, the clomiphene, the letrose, the gonadotropins, and the combination and all. But most of the time I see the juniors, uh, is very important when we are giving a combination, when we are giving a recombinant, in which patient recombinant should be given, in which patient the combination should be given. That's very important. And believe me, individualize each and every patient is very important. And we have to individualize each patient in the OPD. When the patient is coming to your OPD, it's very important if the patient is totally raw, she's coming to you for the first time, or the patient has multiple stimulation and coming to you like is very senior. That's very important. So when a patient comes to your OPD, first of all, try to extract each and everything from the patients. Like it's very important, the age we all know, the BMI. Apart from that, was he stimulated some other clinic? What injections was given? And try to find out the flaws from that. That will be your, in that way you can succeed. So once you framed the patient like, no, she is a patient who has come for the first time and the male factor, or she is a patient of poor ovarian reserve, already given lots of gonadotropin. So already in the frame, one thing is there, how to manage these patients. Then very important is that the baseline scan. That's mandatory for each and every stimulation. Don't call your patient like on 6th day or 7th day, or don't start the stimulation without doing the baseline scan. And again, if you are going for the baseline scan, it's very important to see the ovaries. In the ovary, the antral follicular count, if there any cyst, you have to cancel the cycle. And again, the other things like hydrosalpinx, the fibroid, the polyp, is there any other things which you have missed, or other previous your gynecologist or your colleague has missed? That's very important. So don't always go through whole details of the previous paper. That's very important. Yes, endometrial thickness should be less than 5. It's not mandatory always that blood markers should be done. If you are very good in ultrasound and you are doing ultrasound for each and every patient, like if the AFC is 10 or 12, we can make out like FSH is 6, 7. So blood marker and ultrasound marker, both should be, is not mandatory to be done. With a single ultrasound tool, you can make out what to do. But if the patient has been undergone multiple stimulations, it's very important to see all the blood markers as well as the ultrasound markers. So in the blood markers, ET should be less than 50, means there is no cyst or any residual follicle. LH should be less than 4, and progesterone should be less than 1.5. So finally, you have work in the counseling, the age of the patient, the BMI, and the baseline scans, and the baseline blood markers. Then comes the molecule. Suppose your patient is very young and she has come for the male factor. Clomiphene is a time-tested drug. Yes, we all have shifted to letrose. That's the proven. Because again, clomiphene has some anti-estrogenic effect, but the ovulation factor is much more in clomiphene than in the letrose cycle. But letrose has their other benefits, like its action is peripheral, it's not anti-estrogenic, it's very good in endometrium, it enhances the blood flow, cervical mucus is very good. So you have to judge your patients like and again, one important benefit of letrose is also that it prevents premature LS surge. So I think most of the infertility specialists have shifted from clomiphene citrate to letrozole. I'm not going in detail of the stimulation. Yes, we do the baseline scan. And the patient is young, we start letrozole 2.5 milligram, or you can say we can start 5 milligram a day for the 5 days. So if you have taken patient for the ovulation induction for time intercourse or IUI, again you have to give in the dose for 5 days and then follow her for again 6th, 7th, or 8th day so that the size of the follicle. And with letrozole you can add on, or you can start with 5 milligram. So it is very important to see the BMI, the age, the antral follicle, and yes, the most important, the previous stimulation. What the previous stimulation was done, that will give you a learning lesson how to start and what to add. That's very important. Again, we have to understand this basic physiology that FSH is required for the recruitment of the follicle and the combination is required for the growth of the and maturation. Because in the initial normal female menstrual cycle, for the first 4, 5, 6 days, you need FSH to recruit the follicle. And then LH is only needed for the maturation and finally the LH surge. So don't go randomly give recombinant combination on second, third, and fourth day. Because if the LH is high, then what will you do? It will lead to atresia of follicle. Look, FSH defines the ovarian reserve, which you can make out by antral follicular count, which you can make out by age, which you can make out by looking the sonography. But LH is the molecule, right time, right place. That's very important. So there is a threshold for LH. If LH on day 2 is 6, 7, 8, your patient might be polycystic. If the LH is low on 8, 9, or 10th day, your follicle is not going to mature. If there is no LH surge, there is no ovulation. So the threshold of LH, I feel, is more important because you can't change the FSH, but the LH can be synchronized and you can manage the LH by giving more lots of molecule or you can down-regulate the cycle. So the baseline scan, when you are doing the blood marker, if the patient is polycystic, always do go for a serum LH on day 2 because in PCOS patients, the LH is very high. And you start the stimulation and you find the follicle is not growing and pata nahi kya karu. So if the LH is less than 4, then well, you can try to start or you can do the homework, how to decrease the LH. Because high LH will lead to atresia of the follicles also. There are lots of tips and bits, how can we can decrease the LH on day 2 and then start the stimulation. I will coming in the next slide. So this things is very important that we should follow the body physiology. So you have started for the stimulation and you are given the clomiphene citrate or letrozole. Now the stimulation should, if you are going for a stimulation for in IUI or you can say time intercourse, call your patient on day 7 and day 8. Look for the size of the follicle. Normally it grow by 1.5 to 2 millimeter per day. And it's very important that your endometrium should be synchronized with your follicular size. Endometrium is 3 millimeter on day 7 and your follicle is 10 millimeter. Again, how it's going to implant? So you have to add estradiol also. So it's not only how to stimulate and make the follicle, it's how the combined package comes. That's very important. So again I tell because if the letrozole is not going to make the follicle and the patient has come to you for the first time, look, it's very important for the doctor that you know how to handle your complications. Do what the hell you want to do, but you should know how to handle the hyperstimulation, how to handle the complications. That's very important. So if the patient has been come to you for the first time and the patient is totally raw and not been stimulated, go for the low dose step up regime. Gradually increase the dose. And yes, explain to your patient that this may be a homework cycle. I may not be able to make the follicles or sometimes. So gradually start the gonadotropin. Don't like jump and there is 6 follicle and finally you have to cancel the cycle and you are adding gabapentin or you are giving antagonists to suppress the cycle. That's the hell you are doing. So gradually start the stimulation. This we call the step down rhythm. So low dose of FSH is added. And the one important thing is that as I told you earlier, each and every patient has their own individualized the patients. There is a FSH threshold. a point at which the follicle start forming. As you will see, we all are obstetricians. If the cervix is dilated to 5 centimeter, either he adds into or he didn't add into, the patient is going to deliver anyhow. Same is that if the follicle has reached the aphesis threshold, it's going to move on. And yes, it is different for each and every patient. So it may happen like in the step-up regime, you are not able to make the follicle. No issue. You making the patient aware, or you just have keep in your mind that this patient needs 225 IU of gonadotropins to start the follicle. But you have not done any harm to the patient. So this is the step-up regime when we ask for the beginners to start, so that there will be no complications. Suppose she conceived, that's fine. If she didn't conceive, then you can go for a step-down regime, because this time you have become much more wiser. You know how much international unit of gonadotropins this lady needs. So you can start from the higher dose. And the benefit is that less amount of gonadotropins is needed, and a good amount of follicle. And you know at what dose she will start forming the follicle. But again, in experienced hand, we can start the high dose. That's very important. So you can add gonadotropins with recombinant or combination. If the patient is polycystic and you want to add gonadotropins, it's on day 5 or day 6, it's the recombinant FSH, because she is already in high LH. So these things should be always in your mind, which gonadotropins needs to be added and what day you are adding, what is the physiology of the patient, what is the LH count, and these are very important. In an elderly patient on 7th day, if we are giving recombinant, this will not make the follicle, because she is low in both FSH and LH. So she needs a combination. That's very important. So you can give a clomiphene with combination or letrose with combination. So exactly, I'm not going to teach you. It's you to decide which gonadotropins on which day and how much is the dose. Suppose on day 8 the follicle size is 10 millimeter or 12 millimeter, you hardly need a push. I think 75 milligram of gonadotropin combination will be fair enough to push the follicles. And yes, for the IY, we need this optimum thing: 2 to 3 follicles of 18 to 19 millimeter, triple landing of endometrium. E2 should be 150 to 200, and IY between D13 to D16. So this is a happy cycle you have done. Yes, the results is 20%, 25% max to max. But this is the ideal stimulation for IUI. And beyond this, you are making a mess. For the IVF, we have battery. Now we all have been shifted to mostly the antac cycle, the antagonist cycle. Again, either you are going stimulation for IUI or you are going stimulation for IVF. The baseline is the same, either the baseline blood marker or the baseline ultrasound marker. This will be no dominant follicle, LS will be less than 4, endometrial thickness will be less than. So this criteria should be fulfilled. Either you are going for the long protocol or you are going for the antagonist protocol. So in long protocol, normally we start by day 21 of the previous cycle, reach the parameters of the baseline scan, and then add the gonadotropins. I'm not going for the other protocols like ultrasound and all. So I think most of the IVF specialists has now fixed to the ANTAC protocol, which we are normally using. But for the general gynec, it is very important that antagonist is a wonder molecule. Antac, these antagonists we can use. If a patient taking a patient for IUI, you have a very good follicle at 18 millimeter or 20 millimeter, and you just want to give the HCG injection and planning for the IUI day after tomorrow, like 36 hours or 38 hours, you are planning. But unfortunately, husband is coming in the evening, or there is a Sunday, or you have some program, or you have some conference. So you can give an antag and just hold the follicle. So for the general gynec or the level 1 clinic, antag can be used in this way, like for the holding the follicle, and it holds for 24 hours, and then it's in the SCG. And again, when we are using this antag in IVF cycle, normally we start the stimulation on day 2. The baseline is the same. And again, for the first 4, 5, and 6 days, we need FSH only. So here we give recombinant FSH, and then we start gonadotropin. And again, which we are adding the Antec, there are two protocols, either the fixed or the flexible. For the younger generation, for the newer one, we say that go for the fixed protocol, like start Antec when the by day 6. And for the experience, when they can start when the follicle reaches 14 millimeter, till they are giving the triggers. So these things should be kept in mind. So for any protocol, like for IVF, we are also giving soft protocol. Young patient, we are doing the ICSI, the count is, sperm count is 2 million, 3 billion. So we can go for Letrose plus HMG and make 6 follicle and go for this. So stimulation is basically a mathematics, I normally tell you. Follow the body physiology, follow the patient BMI, follow the patient age, and then wisely choose his molecule. It's not like this molecule is given to A, so the same molecule is given to the B. Again, there are lots of newer protocol like um, for the elderly patients, like she is 40 and needs their own egg. We can go for double stimulation. I will show you the pic like here. So you can start the stimulation and do the pickups. And she has the antral follicular count of 4 only, but she's very adamant she's 42, only 4 antral follicular count, but she needs her own egg. So we've started the stimulation, we have done the pickup, but there are 2 or 3 follicles which are 7 millimeter, 8 millimeter. So you can restart the stimulation and do the pickups. So these are the latest tips and bits in those patients who are poor ovarian reserve and needs their own follicle. So we can extract the oocytes, do the pulling, and then do the transfers. Similarly, similarly, we can start emergency IVF, you can say, or random start. Like suddenly someone has been diagnosed by cancer, and so any day can start the stimulation. These are different study which say that any phase you can start, but this will not be in a routine, only when needed. So luteal phase ovarian stimulation, numbers of studies say that oocyte stimulation can be started in early follicular, late follicular, and even in luteal phase. So I've been allotted 20 minutes. I will finish in another 2 minutes only. So double stimulation or dual stimulation can be done in patients where there is a need of hour, not in the fashion way. Anytime you can start the stimulation, but that should be the need of hour. Like she had to undergo chemotherapy or some chemotoxic drugs or radiotherapy only. Again, there's some new thing is that progesterone you can use to prevent the Allen surge. Very quickly, I will go for the triggers. Normally, we are giving the SCG, especially in the IY cycle. SCG is the bone, and we are giving the SCG when the follicle is between 18 to 22, and 34 to 36 hours, we are going for the IY, or you can say the time intercourse, we can ask for that. But again, if the follicle didn't release, we can go for double trigger. और if she had a history कि नहीं मेरे पिछले वाले गांडे के पास में तो अंडे रिलीज ही नहीं हुए थे, so we can go for double trigger. So anyone is good. Like it's not like recombinant is good. Study says that either you go for urinary, you can go for recombinant. Anyone is very good because basically we need serum LH 15, and even 2000 international unit of SCG can provide. So to conclude, I will say like for me and for all my students, I say that this is a mathematics, and we have to individualize each and every patient and then decide which protocol. If if you are a beginner or if you are taking patient for the first time or undergoing stimulation, be very precise with the molecules. Which molecule, which day, and how much is the amount. That's very important because here, if there is a failure, people will accept. Pregnancy नहीं आई कोई बात नहीं, अंडे नहीं बने कोई बात नहीं. But if the patient lands in ovarian hyperstimulation syndrome, that's the mess and that gives a very bad name. So uh, choose your patient wisely. It's very important to choose your molecule wisely and individualize each and every patient. Then only you can give the good results. Thank you and thanks for your patience listening.
Thank you, ma'am. Thank you so much for such a nice presentation. You almost covered all the things So I'm happy to see so many my friends have joined across the geography. Dr. Samuel from Africa, Dr. Chinwe, and so many other friends have also joined. I am able to see the one question from Dr. Rubina. Yeah, ma'am, I think the question must be visible to you also. I'm just
I
reading.
was just
Yeah,
saying,
yeah. She wants a Dr. Rubina has writing that please give the clarity in the step-up protocol of letrozole.
yeah. So once again, I thank all the viewers of Ritu and all the doctors who have joined the globe. Thank you for joining us. And Dr. Rubina, very nice question. Like the stepper protocol, which I discussed, and they again for the litros, they are battery of litro protocol for litros. So these are two different things. I will just discuss both the things. Um, so the stepper protocol, which I discussed here, is that for a patients like you have taken for stimulation for the first time, and they too have gone through all the baseline things what we have discussed, and you have started letros on day two, and seen a very young patient who have been given 2.5 milligram of letros for 5 days. And again, now it is day 7 or day 6, you have called for the scanning. And on the scanning, you find that the follicle is hardly 5 to 6 millimeter because this patient is a polycystic patient. I imagine like, and the antral follicular count was 2 to 3 millimeter on day 2, and it was 8 to 10 AFC on both the sides. You started with 2.5 milligram of letros. On day 6 or day 7, you call the patient. There is 8 to 10 follicles of 6 millimeter or 7 millimeter. Again, I tell to all my friends and my students, do your scan very wisely. Don't send the scan to the sonologist because they monitor only the follicle which is more than 10 millimeter. I always say, they say no, they write there is no dominant follicle. But what the battery of the follicles which are behind this dominant follicle? Or they will write only 10 millimeter single follicle. You will feel that एक ही अंडा है 150 दे देती है gonadotropins. So do a scan and you will see there is one follicle if it is 8 millimeter and there are 6 follicle which is 6 to 7 millimeter. So if we are going to give 150 milligram of gonadotropins, in the next scan after 2 to 3 days, there will 7 to 8 follicles which will be 12 millimeter or 13 millimeter. And then we'll say, Are baap re, kya karu? So in a stepper protocol, we start with very small dose. If she is a thin PCOS patient, we give 37.5 and gradually we start. And after third day or second day, again we monitor. We look for the growth. If it is less than 1.5, normal growth is 1.5 to 2 millimeter, and the follicle is resistant or not growing, we will enhance the dose. Suppose we have started with 37.5, we will do it 75. And again, we will give 3 doses and again call for the scan. It may happen that on day 10 or day 11, the follicle didn't grow or the follicle started growing up. That is your FSS threshold at which the follicle started growing. This is the stepper protocol. I just touched the stepper protocol and jumped because the time was short. And regarding the letros dose, suppose you are given letros for 2.5 milligram. I will give 5 milligram. What Ritu will do, she will start 2.5 milligram on day 2, 5 milligram on day 3, 7.5 milligram on day 4, and then again increasing dose. In this way, we can step up. This is one protocol where we give 5 tablets of letros on day 2. So there are letros as a different protocols, and so you can try on your own.
Very correctly, you have mentioned, Sangeeta ma'am. As madam has clearly pointed out, see, for us gynecologists, yes, of course, the basic follicle monitoring we have to do ourselves. We have not to have dependent on the sonologist. क्योंकि I can say, जैसे डॉक्टर फिजिशियन के लिए स्टेथोस्कोप है, वैसे हमारे लिए अल्ट्रासाउंड मशीन है. So at least the basic follicle monitoring and the basic obstetric scan, if not up to the NT and anomaly, but at least the basic scan we have to learn. So as madam has clearly mentioned, Dr. Rubina, you have a very valid question. Yes, there are different types of the step-up protocols we are using. As madam has mentioned, yes, one protocol is like that. There are a lot of protocols these days are available if you go through the site for the Cochrane recent advances. So in the Cochrane recent literature of the 2023, 2024 का भी publish नहीं किया है उन्होंने. 2023 में आप देखोगे तो in that it is also published. For this, one is for 2.5, another is published 2.5, 5, 7.5, and 10. And as madam has mentioned, in some patients we are using 5 for 5 days, and then we are extending from 5 to 7.5, and then another for the 10. So that all you have to monitor very properly, very closely, because there is nothing like a tailor-made protocol. For each and every patient, we have to observe very meticulously and then to decide.
Yeah,
Yeah,
very nice.
anyhow, thank you
Thank you. And
for
there's one
joining.
question that how do we bring down high LH in day 2 in PCOS? It's question is from Dr. Anahita. Dr. Anahita, thank you for asking this question. It's a very nice question. So normally, what is the baseline is less than 4. And normally these high LH we find in polycystic patients. So now it is very important that if this patient BMI is very high and she is hardly 25, 26, so you go for the all the management like lifestyle management, exercise, yoga, activity, and if the serum insulin is high, the metformin, mannitol, all the battery of things is given. This is the one type of patient. उनको समझाइए कि नहीं आपकी dietitian, आपका lifestyle. These are other type of patient where the LH is high and नहीं नहीं डॉक्टर साहब ये सब मेरे से नहीं होगा, इट्स नॉट पॉसिबल फॉर मी. पिछली वाली मैडम भी यही बोलती रही, एलएच कम नहीं आया, आई कांट गो फॉर दैट. एंड शी इज फ्रॉम एफ्लुएंट क्लास एंड शी इज वेरी एडमेंट अबाउट हर बिहेवियर एंड लाइफस्टाइल. मैं तो बिल्कुल करती हूँ पर होता नहीं है. बट द एलएच इज 6.2, इट्स 8.1. देन एंड नहीं मेरे को तो अभी आईवीएफ कराना है, माय हस्बैंड इज कमिंग फ्रॉम लंदन एंड ब्ला 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 जो भी. सो अगेन फॉर द if the LH is high on day 2 or day 3, in that case the follicle needs much more push. So again you are worried kya karu, and we all are in a clinical person, like you can understand, we just want we should satisfy the patient also, and we to do justice to our protocol also. So here the wonder molecules comes, GnRH antagonist. So GnRH antagonist is block the receptor of LH. What is the difference between the antagonist and antagonist? Is that the antagonist immediately go and shut the receptors. So on day 1, day 2, and day 3 or day 2, you give one LH. Sorry, you give GnRH antagonist that will block your receptor of the LH receptors, and the LH will come down. And then from day 3, you can start stimulation with high doses of recombinant FSH. This is the second type of patient who is very adamant to go for a stimulation, and because she had lots of money and husband is coming from London. And again the third type of patients comes कि डॉक्टर साहब मेरे से वेट कम नहीं होगा, मैंने सब कर लिया है. So in these types of patients, again you can go for long protocol. We all are aware about the demerits of long protocol. The ovary gets shut down, फिर वो उठने में बड़ी मुश्किल होती है. We need lots of these gonadotropins. So the one T10 myth is that in premenstrual cycle from day 21 or day 22, you start estradiol, giving estradiol 2 milligram twice a day. So if the E2 is high, the LH will come down. But again, it's not possible in each and every patient. So you are worried कि नहीं नहीं LH तो बहुत ही high है, इससे होगा नहीं. So you can add some GnRH agonist starting from day 21, 22 with full dose, that is 0.1 milligram per kg body weight. You can start estradiol plus GnRH agonist from day 21, 22. So that, and giving for 4, 5, 6 days, in the periods come, then this will decrease the LH from on day 2. So this we call it is a long protocol. So in these 3, 4 ways you can do. Ideally, if the patient is young, wait. If the patient is very adamant, go for this and giving an antag and start the stimulation. Or if the patient is cool and serious, one thing next month to kar do, so go for long protocol. You can go for that.
Thank you, ma'am. Dr. Rubina, from where you have joined, from which place? So we can take the another question. And Dr. Anita, sorry?
Rajahmundry, Andhra Pradesh, ma'am.
Okay. And Dr. Anita, you? Yeah, next question we are having from Dr. Madhvi Mistry. Dr. Madhvi, I would like to know from where you have joined. What are the results of the extended letrozole for 10 days? I think we had just discussed, ma'am. Yeah. So now the next question is from Sharajan sir, sir only. Sir is a speaker for tomorrow. Welcome to you, sir. Sir is writing, is there is these protocols how you recognize that the patient may develop OHSS?
So, sir, nice question, sir. So, it's criteria is very important to do a scanning before giving the next dose of gonadotropin. Do a scan. Any follicle, if there is more than 6 follicle or 15 millimeter, the alarm is up. Stop the cycle. No SCG. But at least we should not reach at this point. 15 millimeter से ज़्यादा आपकी 6 follicle है, and even if stimulated for IVF, IVF में we can manage like फ्रीजॉल immediately अंडे निकाल दिया और उसके normally we are doing फ्रीजॉल अंडे निकाल दिया and we can give antagonists and blah blah caberline and lots of things that we can do, but in IVF this becomes the mess. So if we are going for the scanning, it's very important. Apart from looking for the dominant follicle, we have to, जैसे वो कहते हैं ना, आगे एक भेड़ चल रहा और उसके पीछे छोटे छोटे बच्चे चल रहे हैं, तो वो बच्चे कितने चल रहे हैं ना, that's very important. So the infertility specialist should go for the scanning by their own, और वो पीछे की जो भीड़ है ना, that's very important to see, then give your injection. And if it is more than, if 15 millimeters the follicle is more than 6, or E2 is more than 1500, cancel the cycle, never give SCG.
Actually, what is happening? The
जी.
patients are under stress. You
जी.
have taken lot of investments, इतने इंजेक्शन लगा दिए और अब बना कर रहे हो. That is the biggest problem. It's a challenging situation. And this challenging situation is faced by majority of the gynecologists.
Agree, sir.
And that is why my question here is, there should be a specific point that we should plan for our protocol, that OHSS can be omitted. That is most important. Because once you give some injection, it is inside the body. Now it is going to show all their results. That is what.
Sir, believe me, I have not cancelled any cycle for I think more than 5 or 6 years.
Very nice, very nice.
Not
That's great.
Because you have to, and again I tell you, जो आपने बोला कि patient started grumbling, yeah, nobody wants to lose the patient. That's why तो day 2 में antagonist लगा के start कर दिया. But it's very important कि you should first of all recognize, suppose आपके 4 follicle भी बन गए, तो you just give the supportive measures like cabergoline start कर दें, and keep an eye on the patient. Call her even after you give the lupri GnRH agonist trigger. Don't give SCG trigger. Give plenty of progesterone so that the cycle may continue. Choose your patient wisely. Ask not for the having a. If you are doing IVI, that's fine. Even though if you are asking for sex, give her the precautions. कि भाई वो ovary pain and torsion ऐसी चीजें ना हो. Ask her other parameters like constipation and all. So you can wisely choose your patient, wisely educate your patient, and then you can manage. जल्दी बुला लीजिए, बीटा SCG कर ले. By day 12, by day 13, you can make out she's pregnant or she's not pregnant. So these things we do. We did cancel the cycle.
Really, you are taking
becomes
a lot of patience and really focus on that patient, and that is why you are succeeding in avoiding OHSS. Otherwise, it is a really serious matter.
So we are trying to, because it's all the experience matter. I have been in 15, 18 years in this practice and doing only infertility. So these tips and bits we normally do, and the one thing is that no harm to the patient. That should be the funda.
That should
उसके
be.
बाद उसको आपको पैसे वापस भी करने होगा for the weakness I say. उनको बोल दो ठीक है आप इंजेक्शंस की कोई बात नहीं. Next time we will do a discount or something like that. But there should be no harm to the patient.
Exactly.
और अभी आजकल क्या होता है, जब मॉनिटरिंग कर रहे हैं तो पेशेंट खुद ही इतने गूगल से भी टेक्स्ट से भी आते हैं कि पेशेंट पहले ही खुद सब कुछ देख कर आए होते हैं, मैम इतना फॉलिक्यूल आ गया, आप क्या करना है. एज मैडम एज राइटली पॉइंटेड आउट, ऑफ कोर्स वी स्टार्ट द कैबरगोलिन हाई प्रोटीन डाइट, अबाउट द लिक्विड इनटेक, ऑल दैट थिंग्स वी हैव टू एक्सप्लेन द पेशेंट्स. हम नहीं बताएंगे तो पेशेंट पहले ही गूगल से देख के बताता है, मैम उसमें तो हमने ऐसा पढ़ा था. उस सॉरी वी हैव टू
On
स्पीक इन
talking
इंग्लिश.
and they are looking after the Google. आप डॉक्टर
Yes,
साहब
yes.
बता रहे हो, हमको तो ये देखा है.
Yeah.
अभी तो जीपी चैट और ज्यादा इम्पोर्टेंट हो गया.
Yes. Madam, sorry, we have to continue our conversation in English as lot of doctors have joined across the
Right.
geography.
So-
Dr. Dorji has joined from all the way from Bhutan. Welcome, Dr. Uddin. So, Dr. Uddin, I will take all the questions. Yeah, 1 minute. I have just seen. Can you elaborate bit deep into the ovarian cycle and endometrial cycle, madam?
Yeah, that's very important. That's very important. like you were making the good follicle, but the endometrium is bad. It's very important to look over the soil, but where the implantation is going to happen. Like when you are giving the trigger, the it may be 11th day, 12th day, or 13th day. Make a point that it's triple lining, 7 millimeter minimum, 7 to 8 millimeter. So on 6th day you have done the scan, and if you find that your follicle is 12 millimeter, but your endometrium is 4 millimeter, so synchronization have been started. You have to be alarmed up. क्या करना है? So start adding estradiol or ecosprin and cetaphil. These things will be added. So by day 11, day 12, when you are giving the trigger, your endometrium is 7.5 millimeter, 8 millimeter, or 9 millimeter, and your follicle is 18 millimeter, 20 millimeter. Then when they give the trigger. Otherwise, आपने खाना बना लिया पर प्लेट साफ ही नहीं था, and so all go to waste. That's very important. So adding estradiol, adding ecosprin, adding sildenafil, these things are going to help. Other for the IVF cycle, we have battery of things we add, but normally for the general level 1 clinic, these things serve the purpose.
Have you ever tried?
Mostly we are stuck up in PCOS patients. वो endometrium
yes.
बनता ही नहीं 5 millimeter, 5.5 millimeter, because they are in a lifestyle of 60-day cycle or 50-day cycle. So that's why it's very important when you are taking for a patient. For the IVF, it's not so much of worry.
Yeah.
But for the IVI patients, endometrium is always behind the follicle because you are given recombinant, the follicle is formed, the endometrium is poor. So, yes,
Have you
sir.
tried PRP?
Yeah, we do PRP, sir. So actually, the
Hmm.
thing is that normally in my practice or what we feel, if we are going for IUI, we try to keep it cost effective. If we are
PRP
going
is
for,
damn cheap.
yeah, do agree. पर पेशेंट को लगता है ना बहुत सारी चीजें हो रही. If we are going, so I totally agree with you. So we can add GCF, we can read PRP, we can do all these things. But again, with the same patient, those who needs GCF or those who needs PRP, if we are using an IY, we are not going to give 15 to 20% of results. So in that case, we try to mold her to IVF.
That's correct. Yes, of course. But yes, sir, totally agreed with you. Yes, the PRP, we are getting the very good results, but all the patients are not getting agreed for the PRP also. Though we have to do lot of counseling, lot of things we have to explain. Yes, of course, the PRP is having a very good results in some patients, but we have to do lot of counseling. Ma'am, we have received some good comments from Dr. Rubina. We want more videos on this topic in
Thank
future,
you.
ma'am.
Yeah, sure.
Dr. Rubina, please stay tuned. On 16th October, I am having a one more session on unexplained infertility, how to deal the patients of unexplained infertility. And Dr. Shubhalakshmi Chaudhary is writing, thank you, ma'am, for such an informative
Thank you,
session. Thank you for
Subhalakshmi. Yeah.
joining, Dr.
Mm.
And
These are
yeah,
questions from Dr. Anita.
question is from the Uma ma'am. Dr. Uma, if day 3 follicle size is 10 mm, should we give letrose?
Yeah, again, this is very good question. So that's the most important thing is that which follicle you are going to say antral follicle. 2 millimeter, 3 millimeter, 5 millimeter, 6 millimeter, or 10 millimeter. This is very important. So you have seen a follicle that is 10 millimeter. What is the antral follicular count? Is the other follicles 2 millimeter, 3 millimeter, and one follicle is 10 millimeter? Or you have 4 follicles, they all are 8 millimeter, 9 millimeter, 10 millimeter. Yes, but at this point, people say start a stimulation even though it's 10 millimeter. But again, you have done the scan on day 2, the patient has come for the first time, and you are not aware of what was happening earlier. If we have a 4 follicle of 10 millimeter, one thing comes in mind, it's a multicystic ovary. Don't know. If one follicle is 2 millimeter, if 5 follicle is 2 millimeter and one follicle is 10 millimeter, it's a cyst, it's a backlog follicle. These things comes in mind. So here comes the role of baseline scan plus baseline blood marker. Again, you match both the things. And if your blood marker comes in line, if your E2 is less than 50, it's not a backlog follicle, it's not a cyst. And so again, that's very important that we should synchronize the follicle. Synchronization is very important. If anyone has heard the lecture of Dr. Jatin Shah, why to give estradiol in the previous cycle? That's very important. They synchronize the follicles. They synchronize the follicle, and these type of follicle, if 10 millimeter follicle you were getting on day 2, normally we get in the elderly patients, like 35 years. Why? Because these are on chronically high FSH. These are on chronically high FSH. So it's very important to match all the things. But yes, there is one follicle of 10 millimeter on right and two follicle on 10 left. You can start because here the things are synchronized. You can give the SCG also timely. Otherwise, एक 10 millimeter, 4 2 millimeter, so you will get puzzled. So you have to individualize the things. Then you can start.
Thank you, madam. Thank you so much. So,
Thank
friends,
you.
these are the very practical points what we are discussing today. I will take one more question from Dr. Anita. Ma'am, how to get 2 to 3 follicles in letrozole protocol? Already we have discussed, Dr. Anita. If you have missed something, so go through this session. The session is already going live on my YouTube channel. You have to put Dr. Ritu Sanpani. You will get the session details. And letrozole and HMG concurrent or sequential protocol. And giving a comment, nice presentation, lots more to learn. Please arrange few more topics.
Thank you, dear Ritu. Dr. Panigiri says from Billai. Thank you, Panigiri, sir, for nice comments. Dr. Sulakshmi is my student, is very nice. And thank you all who joined. So if any queries or we can close as you said, Dr. Ritu.
Yes, yes. Thank you, Sharajan sir. Sharajan sir also given a nice comment. Super scientific session from Dr. Sidha and hats off to Dr. Ritu. Thank you,
Thank
sir.
you.
And ma'am, there are one more question only I will take, then we
Fine.
will close. Ma'am, there is a question from Dr. Madhvi Mistry. Dr. Madhvi, from where you have joined? In very low AMH patient, what should be the protocol? What should be the cutoff for the egg donation and how to proceed for the higher AMH patients?
For low AMH or for high? Actually, I am not able to see the question.
Ma'am, for both she is asking, for the low AMH also and for high AMH also.
Okay, fine. For low AMH, if you're asking, there are few patients who are very adamant. They just want their own eggs. So in these types of patients, gone were the days when we started the practice, people telling that long protocol पे जाइए, ज़्यादा अंडे बनेंगे. It's not like. So if the patient is had low AMH, oocyte pooling is one of the answer, as I told you earlier. So the start the stimulation, follow the normal protocol. Day 2 baseline things is done, starting with recombinant FSH, enhance the dose, this will be 300 IU, and then gradually shift to combination earlier in elderly patients because here the LH is much more needed than FSH. And then you can do a pickup by day 12, day 13. Suppose you get only 2 follicles and you are able to make only one embryo. Again, here is the role of double stimulation because on the day of pickup, we'll see there is one follicle which is 7 millimeter, the other is 6 millimeter. So normally what we do, we explain these patients कि देखो second time भी तुम्हारे अंडे निकालेंगे, but that's very important. The eggs we have taken out 2 or 3. Like day after tomorrow on 11th, we had a pickup. These patients have done stimulation twice, and only one follicle was formed, and they shifted to intrauterine cycle. And again, she came crying to me, "Madam, aap kuch karo." So I've started, and we're very happy. On day 10, she had 3 and 3, 3 of 14 and 3 of 12. So at least the follicle, and we are going to pick up on 11th. But again, I've explained even though there is 4 or 5 follicles, it may be we may be able to only one good oocyte embryos. So we may go for double stimulation. So here comes the role of double stimulation and oocyte pooling, making the embryo and transmitting later on. And for high AMH, I feel that's more worrisome because here, so for high AMH patients, if you are going for IVF, stay cool because you have battery of things to be done. If you are not going to transfer, that's most important. And you can manage the hyperstimulation. You can give the agonist trigger. So high image polycystic patient, the plan is that first of all, freeze all the embryos, GnRH agonist trigger, give carvalin prophylactically on the pickup table, give colloids so that there may not be shifting of fluids from higher compartment to lower compartment. So these are the baseline you have to do, even though you feel नहीं इसका hyper नहीं होगा, मैं तो leupride, मैं तो GnRH agonist trigger दी हूँ, but that's mandatory on the table at the time of pickup. You ask your anesthetist कि मैडम इसको एक bolulite लगा दीजिएगा. Normally in these patients we give the depot injection so that the ovary is suppressed for long time. If we are worried Then we give antagonists also a day after, and cavalier as a protocol we give. So high AMH are more worrisome than the low AMH, I feel.
Thank you, ma'am. And thank you, Panigri sir, for also for joining. May I request Sahiti to please share
Yes,
the
ma'am.
certificate? Thank
So
you,
nice.
Sangeeta ma'am. This is a
Great. Thank you.
certificate of appreciation for contributing as a distinguished speaker for 9th October session 2024. Ma'am, once again, thanks a lot for joining and sparing your time for this session. Please stop sharing the screen.
Yeah.
So, because my motto of this program is only for the knowledge sharing, as knowledge is power. From last 3 years with my Mata Rani blessings, this program is still going constantly very well. Means I have not to do very much efforts for publicity. I post and lot of doctors across the geography will join. So really thankful to all of
Thank
you, those who have,
you, Ritu, and hats off to you and your energy and your
ma'am,
glamour and your
ma'am.
knowledge. I'm really overwhelmed with you, and really you are very close to my heart. And once again, I thanks all the audience at this festival time. They've spared their valuable time and joined our session, and really their appreciation means a lot for us. At any age, आप बुढ़े भी हो जाए, कोई बोले अरे यार बहुत अच्छा लग रहा है. We feel so good, and so I'm really thankful to all the audience. And thank you, dear Ritu. I love you.
Most welcome, ma'am. Ma'am, request to you, you can organize one infertility workshop. There we can all come. There you can show about your ovulation induction protocols. I will suggest some tips and tricks for successful IUI and all that things. We can
Sure, Ritu, we will manage. Sure. Sure.
Yeah. So friends, with this year winding off for today, and tomorrow we are having a very interesting session with Dr. Sharad Jain sir. How to combat the sexually transmitted infections in the female. And on the 16th October, I am having a session with Dr. Padmaja, how to deal the unexplained infertility. And 17th October, I am having a session with the international speaker that I will declare tomorrow the topic. So stay tuned. Bye-bye. Good
Great.
night. Thank you,
Good
Saidi.
night. Good night, all. Thank you. Thanks a lot.
Thank you, ma'am.
Bye. Stay blessed.